This is one interesting case scenario which I am presenting here. Now there was a 62-year-old male who presented with history of a recent cataract surgery about 2 months back in the left eye, and there was a poor gain in vision following this surgery. The right eye had a poor vision for last 4 years, for he had taken no consultation or treatment, and there was no other contributory history. Now moving on to examination findings, we could see that the right eye had some amount of nuclear sclerosis with minimal of cataract, and anterior segment of the left eye showed presence of a PCIOL which had partly subluxated into the anterior chamber, and one of the haptics and part of the optic was in the anterior chamber, and the haptic was actually touching into the area where the trabecular meshwork would have been there. And there was a patch of pigmentation at the limbus at nearly 8 o'clock, which was extending about 2 clock hours, and it appeared that this might have been a prolapsed iris following trauma. But looking at the pupil and the iris, it didn't appear to be so. The rest of the findings were that the pupil was distorted because of presence of the IOL, and there was anterior synecdoche present in the superior part where the cataract incision must have been created. This was the fundus in the right eye, and here we can see a large geographic atrophy area with a scar involving the macular area, and this eye had a vision of finger counting 1 meter, as could be expected, as the macular area was grossly disturbed because of this disease. We could not ascertain the cause here because it was never shown to an eye surgeon in past, and this was basically a large area of geographic atrophy with SRNVM which had undergone a scarring. So there was no visual potential in this eye. When it was the left eye, we could see there was some amount of haze, and this was because of some amount of posterior capsular opacification. But on keen observation through this opaque media, we could judge that there was some amount of macular edema, and suspecting that, an OCT was ordered, and in the right eye, as expected, we could see that the right eye macular area was grossly atrophied, retina was thin, and we could see some amount of vitreomacular adhesion which was insignificant. The significant part was that the macular area, the retina was grossly thinned out. Left eye, we could make out that there was significant amount of macular edema which was amounting to cystoid changes in the macular area, and this was basically because of result of a chronic irritation and uveitis caused by the IOL rubbing over the iris. So this was basically a case of UGH syndrome, but here instead of having a hyphema, we could see that this was causing inflammatory cystoid macular edema. As far as the issue of glaucoma was concerned, the pressure in the left eye was indeed raised, and it was 45 on measuring this. So this is one example of a cataract surgery which had caused so many detrimental effects because of the poor surgical outcome and probably a complication during the surgery. When this patient had presented to us with this problem, it was obvious that this retina needed anti-VEGF treatment for resolution of this macular edema. And this is the picture at presentation and 10 days after the injection bevacizumab. We can appreciate that majority of cystoid changes in the retina have vanished, and looking closely, now we can appreciate that the retinal contour, the foveal dip, everything has resumed, and this patient had visual gain as well. Now this patient also had some amount of media haze, for which further surgery has been planned by removing the entangled PCIOL which has prolapsed into the anterior chamber and replacing that IOL with a anterior chamber Kelman design IOL. Thank you.